Good afternoon. I don't have any slides. So I'm talking about, as the director of the Institute of Research in Public Health at INSERM and the Alliance for Health Science, AVIESAN. So the Institute that is thinking about what could be the strategy of research and in the domain of public health in general. There are four main domains of development that scientific committees is working on. The first one is the determinants of health, prevention and interventions for prevention. So, of course, linked to the national strategy for health, environment and occupational health. The third one is health services and organization of health systems, so again, research on that aspects, and concept and methods as well that are useful for this type of research and that are really important to develop. And of course, looking at these four domains, you can understand that big data and smart data are really important for all four domains, of course. Public health is a research at the level of populations that truly interdisciplinary by definition, and the main goal is how to get the best possible data for decisions in health policy and clinical and decision in clinics as well. So of course, as much as decisions is involved, the quality of the data is important. So big data and smart data in public health, and that's my second point. Data is the material for public health and for public health research, so it's part of the DNA of research in public health and of researchers. And my own definition, but of course I agree that there is no consensus about what is big data and probably smart data, but and that will be in continuity with the first two presentations, is more that big data is the data that is not only characterized by the volume, as far as I can understand, but because also it's a bit messy. And of course, if you want to take decisions based on analysis of some of the data, you need that it is cleaned and not messy. So probably the definition of smart data is indeed the fact to have really clean data to work on and to provide the best information to take decisions. So so we live in general with the concept or the paradigm that with the data that garbage in results in garbage out. So of course, if you have garbage in as big data, you have garbage out as decision. So we of course welcome the idea of working on smart data rather than big data, but the whole issue is how to transform the big data into smart or clean data, as has been already underlined, and how to deal with the whole data deluge that we are with. So with smart data, which is, so probably we need to transform the paradigm into garbage in, smart out, which is one of the big steps, of course, with big data, with the whole issues of quality, of data personal protection, the issue also of accelerating the use of data. Sometimes we can use, of course, big data, but the big issue is whether that's accelerating really the decision and not the contrary. And the fourth aspect is also that involves cooperation and not only competition in research, because it seems that, of course, we are at the premises of using this data, especially for decisions, but also not only one single team or discipline is able to use this smart data correctly to obtain the right decision. In France, the context is also that we have this very large health administrative data, like the SNIRAM, and of course it's absolutely crucial to use this data and to know how to transform this big data into smart data, and the initiative that has been presented by École Polytechnique is absolutely crucial. What is also being discussed at the moment is the new act or new law on health coming from the National Strategy of Health. The article of this new act, Article 47, would create centralized databases with the SNIRAM, with also hospitalized data of hospitalization, plus at least medical causes of medical data on causes of death, and probably can be enlarged to other sources of data. So that's creating officially and centralizing a really huge administrative health databases, and now the question is how to best use or to make the best use of this data. This would also create the possibility of using a unique identifier, and of course discussing the high level of security that is needed to use this data, that can re-identify the patients. So it's really a big issue. And so at the same time, this new law, has the intention to simplify the process, including for researchers, not only for researchers, but also for researchers, and at the same time identifying the high level of security that is needed with this data. For researchers, the issues are threefold in a way. They are clients of this data, and again, no single team can deal with the high level of technology and security that is needed to use this data properly. But they are also providers of data, especially in epidemiology. They run very big and very big cohorts that can be linked to this data, and that can be very useful for decisions, research and decisions. And also researchers or innovators to transform this data or to use them properly, to invent new ways of using them, representing them, and analyzing them, for example. So really, this new act or new law is a major opportunity for researchers. Now, what can do the INSERM or the Alliance for Health Science is of course to try and organize the possibility of infrastructures that are needed around this data, and for the researchers to accelerate the use of this data. So, for example, the first thing is probably to have the clear position that researchers are encouraged to use open archives, or also to let their data to be used by other researchers. The other thing is also to stimulate the cross-fertilization and sharing across cohorts to strengthen the whole infrastructures that are used for data management. Again, the fact that data are clean is really very important. The other aspects that the infrastructures need to implement is to also diagnose what, in terms of regulation, is needed to use to make the best use of the data, to do the data linkage with other sources, and of course including the cohorts, to ensure the security with probably the principles, and that has already been underlined, that the data should remain where they are, most of the time and as much as possible, and that's the researchers that need to reach the data and not the reverse. So of course the technology around that needs to be implemented. And finally, the idea also is to stimulate the cooperation between the different groups and the disciplines that have part of the experience already to use the data, but cannot have it all, and learning, establish the cooperations that are needed to learn from experiences to improve the way big data are transformed into smart data and used for decisions. So of course that includes researchers in public health, but also that in technology, in new technology, and involves also the industries that might bring the technology that is needed to ensure the right level of security, the right level of data storage, etc. So that's and that's all what I wanted to underline is what we are working on at the moment to really accelerate the path through big data to smart data and accelerate the cooperation between the different actors to use these data.
Good, thank you.
So Pierre-Yves asked me to come today, and he didn't tell me I had to prepare anything, so I didn't prepare anything. But I can
ask you not to prepare anything.
No, but
to be more reactive.
Yeah, so I can maybe do a small introduction. So I'm new to the healthcare world. So I'm an entrepreneur. 10 years ago, I started a company with a friend. That was a company doing recommendation systems at first, and after 3 years, we decided to apply that technology to advertising. And today, that company is going to cross the €1 billion mark this year. Has 16,000 employees in the world, and is trying to beat Google and Facebook on their own turf. So that company is called Criteo. It's listed on Nasdaq. So I left Criteo a few months ago, not because the company is done, but because I wanted to have a new challenge. And it's cool to do stuff with advertising. It's even better to do stuff in healthcare when there are interesting challenges to focus on. So again, I'm very naive when it comes to healthcare because I'm discovering everything. So I was expecting that I could do machine learning, all the stuff that you presented on like very interesting data and save lives and all that stuff. And when I started digging, I was shocked to see that the basic infrastructure to have a clean, centralized database of data doesn't really exist. And so I've been talking to many doctors in hospitals in town. And like just the basic access to data, it doesn't work today. Like you have many doctors in hospitals who would love to access, like, when was the last time you got this X-ray done in town, or like what was the result, etc. Like just a basic file, a patient file. This doesn't exist today. There were many experiments or projects, governmental, etc., in many countries, including France, that failed. So we said, okay, we'll give it a try. So that's kind of what we are trying to do in this new company that I've created a few months ago. So we want to build this repository of data, and when I'm saying health data, it's like real health data. It's not just a reimbursement claim. It's like your DNA, sequence DNA, your X-rays, your blood tests, like real health data. And of course, there are lots of interesting challenges all the way. But I believe that if we manage to do that, and I think there is a way, we could change radically how the healthcare system works in France and maybe in other countries. So the question was, do we believe in linking data, or do we need a centralized?
Your project is focused on data storage, right? So how do you see this project in the whole landscape of currently evolving of the SNIRAM data, the other data, the electronic health records project, which.
So I think we have to learn from past mistakes and try to avoid doing that again. The second thing is it's incredibly hard to change things, right? Especially in this domain, like doctors don't want to change, etc. And integrating into existing systems is super hard. Like when we looked at the existing software available, like we fell off our chair. Like it was really incredibly bad, I would say. So we take a different route. We try to focus on something very specific and do it amazingly well, and try to build a base of users and expand on that. It's if you want to build like super complex system that does everything, most likely you're going to fail. But if you start with something super specific, you do it amazingly well, you can hope to bring a lot of value day one and then build on that. And so we don't want to necessarily integrate with existing systems. We will approach from the side and then hopefully build up the whole system on gradually but surely.
I couldn't resist a couple of comments. One, I really liked the second talk following me, and he raised the issue of parsimony, that you have trouble with these artificial learning systems, that they will find strange patterns and look over many diseases and dimensions that you really didn't want them to. And that, in my mind, is the key role of clinicians, of which I believe there are some in this room, which is you get to help define the atoms of clusters of diagnoses or procedures that are interesting to look at and help inform the dumb computer what clusters to include or not include as it's searching over the nearly infinite number of combinations of variables to use. And that's been the essence of my success of building predictive models where clinicians, doctors and nurses, help define what disease groups you want to include when predicting a drug use or a mortality or heart attack or this kind of issue. But I wanted to maybe be controversial and say on this the last speaker that he's trying to create a data set that will have everything, you know, your DNA, your health records, your medical transactions, and I'm a little skeptical that it might be too early for that. And if I can have 2 or 3 minutes to just tell a story about the United States. Even though we have an okay health IT system, we have horrible adoption of technology by doctors and hospitals. The US still, as of 5 years ago, had only about 20% of office-based doctors using electronic medical records, still a lot of paper records. And hospitals often had electronic health records, but they couldn't communicate to other hospitals, and therefore, if you went to a new hospital or you got in a car accident, they had no way of finding your previous medical history. And so the US has been investing a lot in trying to improve the health IT, and they're including all of these incentives, carrots, bonus payments to hospitals and doctors for doing it. And what they have succeeded is getting doctors and hospitals to install the electronic medical records. They have not been succeeding in getting their doctors to use the electronic medical records. So that they're now trying to figure out, well, they got it all installed. They've received a huge incentive payment for that, bonuses, thousands of dollars, millions and billions of dollars. And now they're sitting there and like that archaic computer that's probably in your office that you sort of never threw away because you're using your tablet or your laptop instead, right? And so the question is, how do you actually motivate using this technology rather than building some bigger, faster, bigger capacity?
Okay. I think in the same way, the same question applies to big companies when they start to install SAP. You have a big project and it changes the whole thing in the company and everybody hates it, right? So I think it's a question of the kind of company you want to build, and we are very we don't want to do that first. I mean, we don't want to build everything at first. We want to be very close to our end users, who are doctors, and help them with a huge focus on user experience, user design, to have more productivity and just so it should come from the base. Like once you have the base, you can convince the top, but you should never do the opposite, or it's very risky.
I'm going to comment on the first thing you said. I completely agree with you. And that's a bad tendency of machine learners. Machine learners, they have the tendency of thinking that they know very well all the algorithms, so they can attack any problems on any domains without having any experts on their sides. And that's a very, very bad habit. I see that students at master degrees, like for instance, they're going to do some sound processing on music and stuff like that, just using machine learning algorithms out of the box that they know perfectly well how to program, but they don't know a single thing about sound. And it's like, there is no way they can do anything good about any application that makes sense. So of course, I completely agree with you. It's very important for machine learners to work hand by hand with the specialists of the domain.
Maybe on linkage and storage are the same place. This is the kind of question that I would like you to.
Yes, and I very much agree that a system to work needs to record the needs of the users probably first, because otherwise you miss the target. So, but also needs to be harmonized, and that's probably one of the problems in France, is that all the systems need harmonization. So coming back to linkage, because we have already the data, so we are not in the process of setting up a new system that can record everything at the same time. We already have the data from different sources. So the idea is more to identify storage places. I don't know how many, but those that can be accredited or certified, where the different data can be sent. And if you identify what is the identifier, then you can link in one place the data and then make it available from clouds or more secured cloud, probably from the researchers. Such a system already exists in France, at least in one or two places, but the idea is that more places are accredited to do that, especially for health data, because the fact is health data has the specificity of being able to identify the people. So really the issue there is that through research or any activity that you, from the use of the data, you cannot re-identify the person, which is not exactly so easy, but at least these data are secured somewhere where it's not it cannot be the data cannot leaked or there cannot be any leakage, and that can be possible only if there are only few places where the data are stored. So that's the principle and the issue.
I think you're referring to the need for harmonization between different. It's true that there's many different IT systems in the health sector, but I think there's different ways to look at this issue. One is trying to harmonize things. The other is trying to make sure that these different systems communicate. And it's a very different way. The harmonization is more like a top-down approach, or like we should define a standard. The other approach is trying to make sure that the systems communicate and between them. And I think it's there's this quite different options there, and communications. I mean, the point which was mentioned is that you may have some IT system in one hospital with a very good medical record, but if you happen to have an accident just close to that hospital, that's perfect because you already have this information. But in many cases, it won't happen. You will have an accident outside and in another place. So the fact that they can communicate may be more important than having something uniform or harmonized.
I very much agree with that, but at least for the data, you need some level of harmonization. From what I know in my own hospital, for example, if I want to put at the same place the same data for just tobacco consumption on all medical records, and I don't cite the hospital where I am, it's really it's really difficult because every clinician has invented its own way of coding tobacco consumption in its own team. So if I want to gather this data together,
Standardization.
So standardization of data is really a condition even in that system, because otherwise you cannot exploit the data.
I wanted to add one insight. I believe greatly in the problem she's identifying, and partly this lack of standardization happens because hospitals and doctors don't know what other doctors and hospitals are doing. And in the United States, at least, the need to prevent patient confidentiality has gotten in the way of supervising and monitoring provider patterns of care. And what can happen is I would love data sets in which they throw away all of the individual identifiers and even the dates if you want. And then all you know is what did Dr. Smith do? And then Dr. Smith and Hospital A, you can track over time and you can compare Dr. Smith to Dr. Jones or Dr. Peters. And then you can find out what's strange about Dr. Smith and tell him or her about it. And that's been a very valuable thing. The Medicare program in the US did something unprecedented a year and a half ago. They just published for every doctor by name every procedure they received, every drug they prescribed, and their volume of donations and money received from pharmaceutical companies. This is public information now. The doctors were amazed that the Medicare program would just do that. And it was terrific because then you could look and say, look at this doctor who did 1,000 of this procedure and his neighbor who's the same specialty didn't do any of them. What's wrong with that first doctor? Or the second maybe, or it could be the other way around. But the key thing is that helps standardize and eliminate some of the overuse or underuse of various procedures. Sorry.
So Emmanuel, and then we will start with.
No, I just wanted to stress the fact that even when you throw away a lot of data, the more linkage you put, the more problem you have for anonymization. And this is a very, very big issue because a lot of people are working on anonymization, but it doesn't really work today. Okay, so I'm sorry, but you have to throw away huge parts of the database in order to work. So there is this thing that we're all fighting with. We don't want to throw away too much things, too much data, but if we want anonymization, really anonymization, we have to throw away a lot of things. And linkage poses this problem.
Okay, so we can take questions from the floor, so please identify yourself.
Okay, I'm Martin Hirsch. I want to come back on the standardization issue. I understand very well that we need standardized information, but my hope was you need standardization for stupid data, but when you have smart data, you should be able to take into account non-standardized data, meaning there are 20 ways to say that a patient smokes, and that your algorithm will be able to take all of them, even non-standardized, to be able to give you the information you need for your research. I would say that's what we're waiting from both of you.
So actually, you're right. So if you have enough data points, you don't really care. If you have, let's say, you have 3 columns, that should be 1, because if you can match them together, you could understand. But if you have enough lines in your data set, you don't really care. Like the algorithm will differentiate the noise from the signal, and you'll have your answer. It's just that you need more data for the same result.
Question?
Luc Martinez, I'm a clinician and general practitioner. So in France, I'm working in the private sector. And what I'm facing with patients, they are complex, with a lot of morbidity, with a lot of specificity. So if you ask me to standardize my collecting of data, I will say impossible. And you will give me some boxes to check, and I will put the check anyway because it's too complicated when I'm facing a patient. So I think that the issue is not to standardize too much, but to be able to connect between the different databases. And I think this is more important than to standardize, because real life is not standardization. And when you face a patient, you are not in a standardized relation, but in a specific one-to-one relation. So I think you have to consider this. Too much standardization will kill the big data because we have only one answer to one question. And probably we need to have more questions and more answers.
My son is a medical student, so I've been learning a lot from him. And he's been rotating around different departments, and he did radiology a few weeks ago. And he hated it because the radiologists sit in a dark room most of the day reading into a microphone what they're observing on the slides and specimens they're looking at. And I agree that would be not my favorite thing to do as a smart person. But the thing I thought was exciting about it is the computer will be happy to take down all the notes of whatever this person says and transcribe it into text using standardized words like diabetes won't be DB, DIAB, DM. It'll all be standardized. So there is hope that computers and voice recognition will greatly facilitate standardization of a lot of this complex, detailed information, which I agree is essential, and I would hate to lose that in the medical records.
Just one word about standardization. I'm talking for research, not for every aspect of big data, but at least what I know is that for research we need standardization because we ask a question and we need the right data to make the right answer. So I'm absolutely confident that with different sources of data, we might end up with a response, or with wrong data, we can have the right answer to the right question. No, why not? But I want to see the concrete examples of that, so comparing the standardized data and the non-standardized data. And if I have concrete examples that are convincing to say that every data can respond to the question, even if it's not standardized for research or scientific questions, I'm absolutely fine. But I want to see the answers.
No, just about standardization. I think everybody agrees that there is a minimum standardization. Even big data people, they all agree that like when you have some text, you have to like the capital letters and so on. So there is a basic. Now the main discussion is about you don't want to standardize as you were doing when you were doing like classic statistics. You don't need this much standardization. So you have to find the right level of standardization.
I'd like to go back to the point you made about randomization, because I think we've agreed on standardization. On randomization, you were suggesting that it wasn't working. The next session is going to be one where we'll be discussing issues with randomization. And so could you elaborate a little bit on that point?
What are you referring to?
You just mentioned randomization and you said it doesn't work. Didn't you? Anonymization. Okay. So thank you. So it was I hadn't understood. Okay, that's fine then, because I was a bit concerned about the next session.
Anonymization is incredibly hard. There were some MIT scientists who proved they could detect who a person was by merely measuring their way of walking down the street with high probability. I mean, it was like, there's so much detail now. But
Or the way you type on a keyboard. I mean, this is a signature. But anyway.
I mean, I actually wanted to talk
Carol.
about anonymisation because I come from England, and there was a throwaway remark made about the fact that patients were worried about being identified. We have a very large administrative data set that we've used in the healthcare research field for many years, which is a hospital discharge data set, and because we mainly have public hospitals, this hospital data set covers almost all patients admitted for almost everything, more or less, in Britain. The real worry there is the data owners are the Department of Health, and the Department of Health negotiate with doctors. So the real worry there is not that you identify patients. That's kind of pretty irrelevant. It's the opposite of what Randy was talking about. The real people who are worried there about being anonymised, the doctors. They are the people who you have to convince when you apply to use those kind of data. But I do think those things, so I think actually international kind of evidence and bringing international evidence together with high-level legal bodies in countries really matters, because we at the same time as doctors generally not liking to be identified, we have had perioperative data mortality published at doctor level within the doctor community now for about 30 years. So I think an awful lot of this issue about both standardization and anonymization comes up against the legal framework of what it's acceptable in a country to allow and what not. And as researchers, 95% of my data problems are not the largeness of my data, because there are people who are very good at that, but the legal issues in some of the data that we use.
I'm Marcel Goldberg. I'm an epidemiologist, and I would like to react on that discussion on harmonization. Personally, I feel it's a little bit confused because there is a lot of ways of standardizing, and also standardization means something if you know why you will standardize for specific analysis. Some things are quite easy to standardize. For instance, when you say diabetes, you can say diabetes, you can say diabetes. That's not a problem. It's not really a problem. The problem is when you want to analyze the data. And in fact, a priori standardization doesn't work in the medical work. It was said, I mean, I want to say what, but when you want to analyze the data, you have to rely on standardization is possible only if the data carries the meaning that you want to. Taking the example of tobacco, if you find in a record only smoker, non-smoker, that is quite often the case. And if, in fact, your project is to look at the quantity, to quantify the relationship between the quantity of tobacco, so you cannot standardize this data. I mean, it doesn't mean nothing, in fact, standardization. You have to take it on case by case, looking at what question you want to answer, and look whether the data are, in fact, standardizable. We are involved in, I'm working in cohorts, we are involved in consortium, European consortium. There is perhaps 15 or 16 different cohorts in different countries, and we want to make analysis, pooled analysis. And we're looking even at the simple thing like level of education. You will find totally different things regarding the country. And if you run to standardize, for most of the occasion, you will lose a lot of information. You finish with 3 levels, which is common to that you can have in common with all cohorts. And so it could be, you have to decide at that point whether it's useful or not so I think that standardization at large doesn't really, it's not really a general problem. You have to really look why you standardize and with which source data.
I can also make a very small comment together with Bakri, when you said about the cleaning also is a little bit dangerous, because sometimes when someone cleans and then you come second, maybe they clean the thing you really wanted to have because they throw away the few rare cases with that sickness that no one has, and then that was the really thing you wanted to have. It's just an example, but unfortunately there is so much heterogeneity which is precious to researchers, and so I guess all these should not be standardized. At the same time, you want to use these data, so they have to be usable. So one has to make some choices and set somewhere, the limit. How much do I throw away? How much do I keep? Some people want to have really clean data, and other prefers to have the raw data, like me. Okay, so. Yeah.
So you should keep the water of the bath.
In the United States, as I said, we standardized quite a bit on the medical records, and they agreed on certain fields that have to be included in a up-to-code qualifying medical record system. But there's still lots of room for entering text fields or allowing additional variables to be collected. And the typical example for these charts is that you have a drill down, like you say the body part, and then it asks you whether it's related to diabetes, and then it asks if it's type 1 or whatever. So there would be some specificity forced on the person entering in the data of how it's coded. There may still be a text field where the doctor can write in no history of diabetes. And then if you're not careful, then you're scanning through for the word diabetes and it looks like it's in the text. And that's just one of the many challenges of the details that you're trying to choose. But, that's a problem. I will say there has been an error apparent in the US in that there's a company called Uniq, UNIQ, which is winning over the vast majority of the medical record industry, including in the Boston area. The Mass General and the Harvard affiliated hospitals committed $5 billion to upgrade and installing their medical record system in all of their hospitals. And I sighed so much because that's like $1,000 per resident in Massachusetts just for the medical record system. Hard to know that it could save money, but it might possibly result in standardization. But before you create your own system, at least look at what the US is doing in all of its usual overkill self. All right.
At least it's going to produce interesting data for research.
Maybe. If they use it.
First, about the cleaning, you have to be aware that when you're working with huge amount of data, the cleaning could be like 1 year of work of 4 people. Yeah. So it's not like I can do it. I'd rather have raw data. Sometimes you just rather not have raw data. I agree with you that you have to keep the raw data. You should not throw it away, but it's important to understand that it can be extremely long. One other comment about the legal problems. People are not really aware of one potential problem is that when you are profiling somebody, like for accommodation and so on, for like buying this book, and you have like different factors, when you run the algorithms, you don't really know what factors you are profiling. There is no way you can know that most of the time. So if you are a regulator that want to forbid certain columns, you can forbid the columns, but maybe you are profiling these columns in indirect ways. So it's there are some really hard problems for the regulator here that I don't know yet how to answer these kind of problems. But it's like an open question. This is very, very problematic.
Okay, so I think we should if there's any last. Okay, so I think we've set up many issues, many problems. Maybe we were kind of pessimistic, or we didn't put forward the whole challenges of all this and the opportunities raised by the use of smart data or transforming big into smart. But I want to thank all of you for your input and reactivity. Thank you.